A great pleasure to introduce Jill Adams, a long-standing colleague from Moorfields Eye Hospital. Jill is going to talk about surgery for restrictive strabismus, which can be very challenging. Thank you, Jill.
Hello, and thank you very much for asking me to talk in this symposium. I'm Jill Adams from Moorfields Eye Hospital in London. Now, I'm going to talk about restrictive strabismus, and most people will commonly associate that with thyroid eye disease, which I'm not going to talk about. I'm going to talk about other areas where strabismus surgeons get involved and the techniques that we can use to try and assist these often complicated and difficult problems. Surgery for diplopia after blowout fracture. This commonly affects men far more than women, and the restriction can be due to muscle entrapment, or it can follow the surgery to repair ophthalmos and the fracture. So it can be sort of primary or secondary. Now, this is a case in point. This is a young man who had a road traffic accident. And as you can see, he's got significant ophthalmos, which was very troublesome to him aesthetically. And although he had no double vision, he opted for mesh repair by the maxillofacial team to improve the situation. And unfortunately, this resulted in double vision. Now you can see here the problem. He's got two plates in. You can see them here and here, and they have gone through and they have damaged and entrapped the inferior rectus muscle. So he's had the plates in for ophthalmos with no double vision, and now he's got double vision, which is very troublesome. So I've listed here the various things that a strabismus surgeon will think about when trying to deal with this problem following blowout fractures. So we can either move the muscles up, we can move the muscles down, we can recess muscles, we can work on the opposite side to try and balance the vector forces. But you have to look at each patient and you have to ask them what it is that bothers them most. Is it worse when they look straight ahead? Is it worse when they look up? Is it worse when they look down? So for this particular case, we had the plate removed by our orbital team, and then I moved the horizontal muscles, the medial and the lateral rectus muscles downward in an inverse nap procedure. So I took them down to the inferior rectus border, and we did a contralateral superior rectus recession and a contralateral inferior rectus farden to try and get him balanced in all positions. So these can be very complicated, and you're unlikely to get them normal motility and perfect in all positions, but you can improve them significantly. Now, retinal detachment repair can result in double vision in quite a significant number of patients. Now, it's less since we've moved to vitrectomy, but it still exists because the muscles are slung to move the eye around, and the vast majority of it will settle, but many patients have persistent problems. It's also not helped by the fact that if it's been MAC off and they've got macular damage, they really find it, they get image distortion, they get scotomas, and it may be very difficult to bifoveally fuse for these patients. But they may also get this sort of scarred appearance where if they've had a band or if they've had multiple surgery, and this sticks the eye down so it doesn't move up, and sometimes it doesn't move down. If they've had to have cryotherapy, the muscles may themselves be mechanically damaged. Local anesthetic into the muscle can also damage it. So there are a number of mechanisms for why patients post-retinal detachment intervention can get diplopia. You first of all got to check with an Amsler chart whether or not the patient has any possibility of fusing. If you put the eyes close together and they still can't bifoveally fuse, or they've got a large scotoma, they are going to still have double vision. In the main, removing the explant doesn't help. There will be a few patients it does, but most of the time it doesn't because there's still the associated scarring and muscle damage. It's a good move to try a prism or botulinum toxin as a temporary solution to see if the patients can fuse. If that works, then it's very definitely worth going on to use adjustable sutures in your squint surgery to try and align the muscles. Aim to recess, not resect, because the muscle does not behave normally. So just as an example, this is a 22-year-old who during the early lockdown got a retinal dialysis. He had a cryo buckle put in. The buckle was removed for infection. He got a very aggressive inflammatory response with scleromalacia and a staphyloma, and he had a huge hypertropia with very limited down gaze. So when I explored him, I found that the inferior rectus muscle was hardly attached to the globe. So what I did was I reattached it without resecting it. And he then had a hypotropia following that, which he was very upset about. And 4 weeks later, he had a large phoria, but he was able to control it with single vision, and he didn't want anything else done. Another interesting condition is congenital fibrosis syndrome. It usually affects the inferior rectus muscles. And there are various approaches. There's a strabismus surgeon that we can use. We can do supramaximal recessions. You can just cut it and let it fly, although I don't think I would recommend that because the muscles will stick to the globe and not necessarily always where you want them or equally. You can consider, if they're divergent, taking the lateral rectus muscles off and stitching them to the periosteal walls or the soft tissue. And for verticals, I find that tutoplast expanders are really a good option. So this is bovine pericardium, and you can cut it. It stitches beautifully. You stitch it into the muscle, and then you use that to expand the muscle. So it's not like just supramaximally recessing it. There is still an attachment to the insertion, so the globes move better. So tutoplast, I think, is definitely something that you might want to think about in these particularly difficult cases. Now, strabismus surgeons sadly can also cause adhesive strabismus, and our classic one is after inferior oblique surgery. If you deep dip, if you damage the artery to the inferior oblique, or you catch the orbital fat, you can get a sort of pseudo-Brown syndrome where you can't elevate. Now, this is particularly difficult for people who cycle, couriers, people who use racing bikes, if you play snooker, if you box, and if you're a dental surgeon, you can't look up into somebody's oral cavities if you get an inferior oblique adherence. The surgical options are to go and explore, clear the graft, but in this situation, you may well find that amniotic membrane grafting is extremely helpful. And you can operate on the other side to bring the superior rectus down to sort of counterbalance. That doesn't always help if there isn't much of a deviation in primary, and many patients, understandably, don't want their good eye operated upon. Now, amniotic membrane graft comes from the amnion around the placenta. It's got 3 layers, and the great advantage about it is that it does not excite an immune reaction, so you don't need to immunosuppress your patient after using it. It reduces tissue adherence. It's been used in ophthalmology since 1940, and it was originally used for surface defects. And that's, I think, where most people will think about using it for pterygium repairs after Stevens-Johnson syndrome. I used to use the frozen, but our institution has moved on to the dried, and I find that this is perfectly acceptable. And it's very good. You can either wrap it around the muscle to stop the muscle adhesing to the globe, or you can split the conjunctiva and put it over the muscle and under the tenons, and it works very well to reduce adhesion. In this situation, you need to use it epithelial side up, and the Omnigen helpfully has a little marker on the surface to show you which way to put it in place. So what you do is you do a force duction test to make sure that it is actually tight. You divide the adhesions, you recess the inferior rectus muscle, and you don't have to recess it as much as you think. 3 millimeters is often enough. Take away the fibrotic conj, epithelial side up, and as I say, there's a little marker so you can show which it is. Eye suture, I'm aware that some people have tried glue. I've never used glue. And I find that traction stitches to hold the eye into the position I want it to rest into for 4 to 6 weeks with Proline tied over bolsters is a really good way to hold the eye in good position. The amniotic membrane has this slightly gluey, mucousy type appearance, and it will heal into the tissue in 4 to 6 weeks. So an example here is a 30-year-old gentleman who had squint surgery twice, and he was worse after the second operation. He had a large hypotropia. He couldn't move the eye on elevation in adduction. So I went through the process I've just described, and we put the traction stitches, and you can see them here tied with Proline around the bolsters. And 5 weeks after surgery, we took the bolsters out, and he was in really good position. So this is not something you would use for primary surgery. It's used for secondary surgery, but I do think it's very important. If you can, use it early. By the time you get down to 7 operations with a restrictive problem, AMG is going to have a very tough job to try and help you. So clear the adhesions and use the graft. You can't do adjustable sutures, and I do think that traction stitches help in this situation to hold the eye in a good position as it all heals. So in summary, restrictive strabismus surgery is a challenging and actually very interesting type of surgery for a strabismus surgeon to be involved with. Most of the time, we cannot make things completely normal. The patient will have some deficit in various positions of gaze. We're aiming to give them primary position single vision, and if possible, usually down gaze, because for most people, looking down for reading or for eating or down the stairs is the most important situation. But there are some people who need to be able to look up more than they need to be able to look down. So you need to have a discussion with the patient about what is and is not achievable. And you have to be very realistic. You cannot promise 100% normality. But what you can say is we can help you, we can get you better in primary, and that will be helpful to you. But as I say, you have to be realistic about what you can achieve. So an interesting area for us to be involved in, lots of techniques to use, lots to think about. Thank you very much.
Thank you, Jill. John.
Jill, thank you very much indeed. One problem that I've seen occasionally is, for example, in a patient who's got some residual inferior oblique scarring, is that you get them nice and straight, then over a period of, say, 6 months or a year, the superior rectus on the other eye seems to start to overact in response to that as the yoke muscle. Have you seen that?
Yes, but I still think that a lot of it is scarring around the inferior oblique. You know, when you go and look at it, you often find scarring between the inferior rectus and the inferior oblique. And I do think that you can get some late scarring, particularly if people have breached the orbital fat pad. And I think that that's why it doesn't happen immediately. And I think the other thing that people forget to do, you need to do duction exercises after inferior oblique surgery. And if you don't do that, it all just glues down or can glue down.
Jill, did I understand it correctly that you suture the amniotic membrane with 8-0 Vicryl?
Yes.
Over what area of the globe?
Well, you basically, rather like the plastic surgeons, if you're putting a graft in, you think of it, you get a number for your sheet and then you double it. And it only comes in 2 sizes on Jen. So I usually just say, can I have the biggest sheet possible? Because I sort of pack it down as well as suturing it around the edges. You don't want it too tight, because if it's too tight and you put your stitches in, it's going to split and it's not going to work. So really, it's kind of, it's packing and laying it into the tissue.
Thank you.